Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on the physicians and practitioners who are redefining medicine through their integrative, functional, and holistic approach to health and well-being.
Welcome, everyone, and welcome to our weekly podcast, Redefining Medicine. We are so lucky to have Dr. Galiatsatos share his time with us today. Dr. Galiatsatos is a physician specializing in pulmonary and critical care medicine and assistant professor of medicine at Johns Hopkins. Welcome, and thank you for joining us.
Oh, it's an honor. Thank you so much for having me.
It could be argued that no other specialized field in medicine has experienced such a challenging period during the pandemic as have the pulmonary and critical care areas. Will you tell us what led you to specialize in these areas and how your work has changed since the pandemic first began?
I think knowing why someone went into the field of medicine that they practice is always going to be a fascinating story, because first you just select that you want to be a doctor, not knowing what you want to be, and then ultimately you choose something at some point in time during your medical school years. For me, choosing critical care in medical school had a lot to do with a really good role model. I love the way he ran an intensive care unit. And the other part was patience. Being able to help them or being able to comfort their families to understand the gravity of the situation just meant a lot. To me, it was a really an enjoyable moment where medicine really is at its peak, right? With all the interventions we can do to help save a life, or recognize we can help transition it to kind of the natural state. So critical care medicine was something that I really loved going out of medical school, and then in residency was reaffirmed, right? I went into internal medicine training and I still continued falling in love with it. Then I did my fellowship in critical care over at the National Institutes of Health in Bethesda. Actually got to meet Dr. Fauci before he was the Dr. Fauci, when we helped care for patients with Ebola during that time period. But critical care medicine is everyone's field of medicine people love. And for me, critical care is just, it's rooted in physiology. It's rooted in severe disease at immediate times, but it's also rooted greatly in humanity, because we have to be there, not just to comfort the patient, but the families, right? We've done this maybe thousands of times. It's the first time a family member may see someone this ill with a breathing tube, not understanding this sounds very unnatural. And during the pandemic, that humanity was probably the most challenging part for us because it was robbed a lot of times, right? When you have a family bedside to see the patient struggling, you're able to convey, they can see it, like, I get it. You should let mom, focus on comfort and take it from there. Or, mom looks like she's turning around. This is great. I get excited. When you're on Zoom calls, right, because families couldn't come in because of COVID restriction policies, it was tough. It was really tough to convey that. And, we became kind of family for the patients during this time. And I say this because while that sounds great, there was a lot of hands I held, as I was the last hand that they held as they passed away, because families didn't want them to pass away alone. This was probably the hardest thing for a lot of my colleagues, right? We know we deal with death, don't get me wrong. And we're able to somewhat compartmentalize it and move on. That we find ways to kind of let our human side come out, and we find ways to go and cry. We did a lot of crying during this past pandemic, and we still loved our field, don't get me wrong. But this was, it was taxing. It wasn't so much the work. And that was taxing too, but it was the emotional toll that it took on us. That's the part, the ability to lose the humanity, which for a lot of us is why we love doing what we do in the ICU and the intensive care unit. That being lost, that hit us hard.
Thank you. You will be speaking at the upcoming event, COVID-19, a primer update from treatment to long haulers, taking place July 17th and 18th. Will you provide us with a preview on your topic and share with us why this information is so critical for clinicians to understand?
So surviving a critical illness is never the end of the story. It's not patient A survived sepsis and lived happily ever after. It's not. There isn't usually a fairy tale ending for these patients. And we as a medical profession get so biased with surviving. you survived it. And these patients, they're still not back to themselves. And they're like, well, all this attention to get me to survive, and now I'm here and I'm learning how to walk again. I'm learning how to breathe again, learning how to be myself again. How do I do this? And we've seen this before the pandemic, right, with a lot of survivors of other critical illnesses, and we're seeing it now a lot in the pandemic. So the preview to know what we're going to discuss is, how do you fulfill the promise of medicine to the survivors where they feel left alone after surviving COVID-19? How do you fulfill that promise? How do you give them the reassurance? How do you give them the comfort? How do you give them medicine? And I say this as a field, not like a pill, but how do you give them the field of medicine at a time where we're struggling to help these patients? And so I want to prepare people for that. When they come to listen to this, we're going to go over why we think we're going to see a lot more of these patients come out needing the type of care that we're going to provide. And then we're going to discuss what that means. How do you efficiently manage long haulers, patients with ongoing post-COVID-19 complications? How do you manage them? And if you don't, you're setting them up for a lot of complications that you could have prevented if we got the right team involved. That's what we'll cover.
The Delta variant of the virus appears to be the most common strain for new U.S. infections. Has your clinic encountered this variant? And if so, what can you tell us about what you have seen in comparison to previously dominant Alpha strain?
So have we seen it here in Baltimore? We haven't seen it. I think maybe we had one case so far, so it's hard for me to speak on it from a clinical standpoint. However, being kind of still involved with care across the nation in some other ways, we have heard others kind of weigh in of what they're seeing. And the concern we have right now is that our COVID cases that I'm at least being discussed about aren't because during the pandemic, you had kind of a spectrum. You had patients being hospitalized and they may just be on the regular medicine floor, maybe in the intensive care unit. But I feel like I'm hearing a lot of from my colleagues is just a lot more intensive care unit admissions without a lot of just general medical floor admissions. So my concern with the Delta variant is, is this a coincidence? It happens to come here and we're just seeing a lot more ICU admissions. Is that knowing that we have a virus that's easier to transmit, and if you get enough viral load in it, is that easier transmission, you're likely to have more severe disease. So my suspicion is, the field of critical care is probably going to see a lot more of these patients into our ICU. And so that's what I just want to prepare everyone. The one thing I do want to emphasize is we have an antidote. To date, I've yet to see a vaccinated individual landed in my intensive care unit struggling with COVID-19. I still have a few COVID-19 cases. I can't speak to them having the Delta strain, but they're sick. And the one common theme they have across the board is they haven't received the vaccine for whatever reason. So I think knowing we have this variant here and simultaneously knowing we have an antidote to prevent this from becoming lethal and to prevent other, variants from coming out, I think, science needs to recognize we need to promote this messaging in a manner that aligns with our community and their priorities in a manner that's is easily understood. We need to do that work, right? We can't just focus on the clinical settings. We've got to go out and engage with the community in real time.
In addition to your clinical and teaching work, you are co-chair of the Johns Hopkins Healthy Equity Steering Committee, as well as the co-director and co-founder of Medicine for the Greater Good. Will you tell us more about both of these roles, how they came about, and what they consist of?
So the way these came about is, and I think everyone recognizes this, and especially during the pandemic, there are populations here in the United States and all over the world that are disproportionately impacted by certain diseases. And why that exists, medicine would love to say it's down to the genetics. It's not the case. The majority of the cases, it's down to kind of the sociological constructs and networks that have been created and so forth. And so my role as an individual, as a co-chair for health equity, is to make sure that we can identify these differences and see the populations that are being ravaged by COVID-19 in a disproportionate manner. And then with Medicine for the Greater Good, can we do something about it? So Medicine for the Greater Good really entails community engagement. And, whenever I get asked, how do you how do you do community engagement as a physician? Like, what's the one thing you got to teach me? I tell everyone the first thing you got to know for community engagement is know medicine really well. This always comes as a shock. So like, well, what does that mean? I was like, because if you know medicine really well, you know what it can do, and you also know what it cannot do, right? You know what it can't do, right? Especially during this pandemic, you know it can't get people to wear face masks unless you talk to them to help them understand. You can't just put it on a billboard and call it a day. You know it's not going to overcome, the conversations about food access. You know it's not going to overcome the conversations about transportation. You recognize that health and medicine are not synonymous, and that holistic approach towards health, which is important, especially during the pandemic, needs to be at the forefront to helping our communities prevent COVID-19. So health equity to me gives me kind of the map. All right, I see the areas that are being ravaged. Medicine for the greater good is that vehicle that gets us into those communities, to engage with the communities, to align their community health interests with our population health strategies to prevent disease, specifically COVID-19. And in that case, also promote wellness. That's it. I mean, to me, medicine has to engage with the community, has to promote the science in a manner that the community understands and can align it with their own culture and their own goals. And you got to work with communities that, individuals seek out and trust in, like your faith-based organizations, your schools. I always say, medicine is to be a public trust. It needs to work with entities that have the public's trust. And so that's what medicine for the greater good is. It's that ability to teach physicians how to engage with the community for the ability to do something, to do a greater good.
How would you define the term physician citizen? Why is this so important? And what advice do you have for clinicians to become physician citizens?
So from my standpoint, in academia, we have a variety of, we have physician scientists, so they work with patients and they go back into their labs. We have physician educators who are masterful teachers. I make it clear we need to have physician citizens, people who understand the importance of community engagement and go and execute it daily. Knowing that is going to be important because that allows us to work with the community to promote the science, prevent disease. And it's not selective for any physician, it's got to be for all physicians, right? If you are funded by the NIH at any level, that comes from people's taxes. You got to go out and talk to the community about your research. Talk to them so they can still understand what you're doing. If you have a way that you want to impact your community to allow them to stay healthy and what that means to them, do it. Go out and engage with them. From my standpoint, community engagement, I think over the last year and a half, the significance of it was palpable. Clearly, we can't just sit back at a podium, share guidelines, call it a day. Dr. Fauci made a quote in March of 2020 in the Washington Post when they asked him, hey, what did you learn from the AIDS epidemic that you're utilizing now? And he made it clear, it's like, you got to work with the community. You got to understand their struggles, their barriers, because that means you got to help them adapt towards what we're recommending. Because if they can't adapt, they're going to fall ill. And that's what we saw. Who was emphasized a lot during this pandemic were medical community partnerships to get COVID-19 testing, to get COVID-19 information, create peer-to-peer educators out there. That can be done well and efficiently with physician citizens. Physicians who know how to engage with the community, who can go out there with a cultural insight, can go out there and create a homophily with the community that gets messaging to be received in a transivity manner from one person to the next. That will be powerful. And from my standpoint, that shouldn't be seen as a novelty. It should be seen as a necessity for every healthcare system. Because the next time we get another public health crisis, you can't just flip a switch and just say, hey, community, trust us again. Here's what we got to do. No, you pull on the strengths of the trust that you formed, and you say, hey, for you to do well, here's what needs to happen. Otherwise, you're going to get a lot of sick patients again who will overwhelm all the hospital systems again.
Thank you. And final question, what would you say has been your greatest takeaway from your experience in working to integrate equity into your care approach?
And I said this earlier, the promise of medicine. right? That hasn't been seen by a lot of individuals. Because, like you can copy and paste a regimen, but it's going to work differently for different populations. I think the biggest thing that I've seen when integrating health equity is the appreciation of how small a healthcare system plays in mitigating healthcare disparities and taking them away. How many cities out there in the US have some of the best hospital systems? And Baltimore, Johns Hopkins, Cleveland Clinic in Cleveland. And those are some of the cities with the worst healthcare disparities. So I think what I've become humbled by putting in this work is, even though I feel the full responsibility of a patient's health outcomes, I'm realizing I can't do a lot to prevent the disparities from occurring because they're grounded more and more proximal factors like education, transportation, housing, food access. So by integrating this notion into my practice, suddenly I can become more of a patient advocate by going out and helping these entities feel responsible for those outcomes and using that sensation of responsibility to potentially help us turn a new chapter in managing patients from birth to death holistically in a manner that will ultimately end healthcare disparities. It's not going to happen from a hospital. It's going to happen from a collaboration with all entities feeling accountable for the health of their community. To me, that's the ultimate, by the way, culmination of a physician citizen, to know how to navigate those waters where he or she can help the community at large.
Thank you so much for sharing your time with us today. We truly appreciate you.
No, it's an honor. Excited to take on the event in a few weeks, but just an honor. Thank you so much.
Thank you. And thank you to all of our listeners for joining in. Until next time.